So you ready?
Yeah. Good afternoon, everybody. Thank you for joining us today. This is the Appropriations Subcommittee on Health and Social Services Subcommittee hearing on February 5th. We will be hearing today in this order from the Maryland Department of Health Prevention and Health Promotion Administration, followed by the Office of Deaf and Hard of Hearing, and then the Department of Disabilities. Thank you all for joining us today. I apologize for starting us a few minutes behind schedule, but we will begin, as we usually do, with our wonderful analysts for prevention and health. Thank you for joining us today.
Thank you, Chair Shetty. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services. I'll be presenting the fiscal 26 budget for the Prevention and Health Promotion Administration in the Maryland Department of Health. This administration includes the Bureau for Maternal Child Health, Infectious Diseases, Environmental Health, and Chronic Diseases. The fiscal 26 budget increases by $7 million over the fiscal 25 budget to $531.5 million. On page 4 begins discussion of some of the performance goals that FIPA monitors and reports on. The first is related to cigarette usage among adults and children. Exhibit 1 on page 5 shows that the proportion of adults, middle school students, and high school students who use cigarettes has been decreasing since calendar 2011. And FIPA's actually surpassed its goal for adults several years in a row to decrease the proportion of adults who use cigarettes. FIPA has also aims to reduce any tobacco usage among middle school youth and high school youth. Exhibit 2 on page 6 shows usage of electronic smoking device and all products among middle schoolers and high schoolers. There were modest increases in ESD usage for middle schoolers and for all products for high schoolers and middle schoolers between calendar 2021 and 2022. We have asked FIPA to explain why the proportion of high school students using any tobacco products during this time increased, while the proportion of high school students using individually cigarettes and ESDs decreases. We've also asked FIPA to indicate how it will update its MFR goals around adult tobacco usage, given that it's met its goal several years in a row. There is funding that is mandated for tobacco cessation in the budget. The governor must include at least $18.25 million annually in the budget. This funding has been included since fiscal 2023. The fiscal 26 allowance includes $24 million for this purpose. And so DLS recommends reducing the fiscal 26 allowance by $5.7 million in general funds in order to fund tobacco cessation programs at the mandated level. Moving to the second MFR is related to unintentional cannabis exposure. Starting with the submission for fiscal 26 MFR data, FIPA started including a couple measures related to cannabis usage. Exhibit 3 lists out those performance measures. They're unintentional exposure to cannabis among children ages 0 to 9, and unintentional exposure to cannabis among Marylanders of all ages. The MFR submission to measure each of these metrics includes poison control call data from 2 different poison control centers in the state. Exhibit 4 on page 9 shows the number of calls to poison control for unintentional cannabis exposure. The number of calls significantly increased between calendar 2021 and 2022, which was driven by calls for children ages 0 to 9. This chart also notes the date of adult use cannabis legalization beginning with the start of fiscal 2024. In June of 2024, MDH also launched a data dashboard on its website with public health data related to cannabis usage in the state. The data can be disaggregated by demographics like age, gender, race, geography. And then FIPA also indicated that it would include 2 additional MFR measures with its fiscal 28 submission, and those are listed on page 10 in Exhibit 5, related to the cannabis use prevalence among high school students and middle school students. Chapter 26 of 2022 established the Cannabis Public Health Fund, which receives revenue from taxes on adult use cannabis. And is meant to be used for education programs and public awareness programs related to reducing cannabis usage among youth. FIPA reported that as of January 2025, it had expended $5.3 million to date from the fund, including money going toward local health departments for educational programs, money for a media campaign, and then funding to support the Legal Resource Center for Public Health Policy. The fiscal 26 allowance includes $6.2 million in special fund expenditures from the Cannabis Public Health Fund. The third performance measure that I'll discuss is around sexually transmitted infection rates, which are increasing in Maryland. Exhibit 6 on page 12 shows the rate of syphilis infections and chlamydia infections in the state. There is no data available for 2021, and so that is why there's a gap in the chart. But these rates have largely been increasing, besides a slight decrease during the COVID-19 pandemic. FIPA also produces annual STI epidemiology profiles with more detailed information on STI rates in the state. The 2023 Maryland Annual STI Epidemiological Profile revealed large disparities in STI rates between different genders, people of different ages, and across racial and ethnic groups. In response to this, FIPA reported that it was reorganizing their Infectious Disease Prevention and Health Services Bureau to reduce silos and better address these disparities. Page 13 starts discussion on prior budget years. So it starts with a discussion of fiscal 24 closeout information. At the close of fiscal 24, FIPA canceled about $57 million, mostly due to unused federal COVID-19 stimulus funding that MDH indicated would be used in fiscal 2026. It also underspent in MADAP due to the special funds lack of availability of special funds, and then $2.9 million for abortion care access programs. In fiscal 25, or rather the rest of page 13 and then on to page 14 summarizes some of the budget actions taken affecting the fiscal 25 appropriation, including a cost containment measure authorized by the Board of Public Works in July, and the implementation of several different legislative priorities. There is a proposed deficiency included in the fiscal 26 allowance, which would support the funding for which would support the breast and cervical cancer diagnosis and treatment services program. The deficiency withdraws about $4.7 million in cigarette restitution funds. Those are special funds due to a lower than anticipated fund balance, and replaces that amount with general funding. Moving on to fiscal 26, Exhibit 7 on page 15, apologies, which I am missing, shows the breakout of the entire FIPA budget. A majority of that funding, 40% of that funding, is allocated to the Maternal and Child Health Bureau, and then you can see on that pie chart the breakout for the rest of the bureaus. Page 16 and 17 summarize the major differences in the budget between fiscal 25 and fiscal 26. So again, the entire budget is increasing by about $7 million. The largest changes are related to federal COVID-19 stimulus funding. There's an increase of $61.3 million due to extension of a CDC grant, which is the Epidemiology and Laboratory Capacity Grant. That's for COVID-19 testing and surveillance activities. the funding was, again, the expiration date was extended, so MDH is able to use that funding in fiscal 26. And then there's also a reduction in stimulus funding due to the expiration of some other federal grants. Found my pie chart. Moving on to page 18. 18 and 19 describe some of the other changes in the budget. MDH is realigning several of its programs within the department. And in FIPA, this is accounting for a decrease of $17.8 million. Mostly this is driven by about $17.5 million reduction related to harm reduction services and programs that are moving to the Behavioral Health Administration. There's also a decrease of $2 million for the Center for Firearm Violence Prevention and Intervention, just because that's moving to the Office of the Secretary. Page 19 has a brief discussion on the Budget Reconciliation and Financing Act. The 26 allowance does include a special fund reduction of $13 million for the statewide Academic Health Center Cancer Research Grant Program. This is contingent on the BRFA. One of the provisions in the BRFA would eliminate the mandate for this program. And this program, essentially, they give grants to the University of Maryland Medical System and Johns Hopkins for cancer research. Under personnel, the fiscal 26 allowance includes 569 positions in FIPA. The reduction of 12 regular positions is internal transfers moving to the Behavioral Health Administration. Those roles were supporting harm reduction services. The vacancy rate as of December 31st, 2024 in FIPA is 18.68%. We have asked FIPA to comment on the job areas and function of these vacancies as of December 31st, 2024, and discuss the impact that this vacancy level has on agency operations. Moving to page 21, the first issue that I'll be discussing is related to HIV and AIDS services in the state. So the state receives revenue to support these sorts of programs from pharmaceutical rebates that get deposited into the MADAP fund, and then formula funding through Ryan White. Exhibit 9 shows the changes in the cases of HIV and AIDS diagnoses from calendar 2020 to 2024. Essentially, this funding is dependent on the number of new infections in the state. So because infections are going down, the level of funding is also decreasing. As a result, FIPA indicated that the special fund spending from MADAP will also decrease just to align with the estimated revenue. Exhibit 10 on page 22 shows the legislative appropriation and the actual spending from MADAP, as well as the closing balance. And so you can see that the closing balance did hit zero in fiscal 2024. The fiscal 26 allowance includes $39 million. This is level funded from fiscal 2025. Because of this decrease, DLS has asked FIPA to indicate which services and grants have been reduced as a result of the decreased MADAP rebate spending and how it plans to support these programs moving forward. The second issue, starting on page 23, is related to the Pediatric Cancer Fund, which was established by legislation in 2022. The fiscal 23 budget under the Office of the Secretary included $5 million for the fund from the dedicated purpose account. FIPA experienced delays in administering the program, and so the fiscal 24 budget allocated an additional $5 million, which was then withdrawn in fiscal 2025. The fiscal 26 allowance does not include any additional revenue for the fund. In 2024, additional legislation established a Pediatric Cancer Research Commission, which would help administer the fund. As of January 2025, MDH reported that 7 of the 12 members had been appointed, 2 were awaiting swear-in, and 3 were in active recruitment. MDH also indicated that any fiscal 26 expenditures would be dependent on fully appointing the commission. Given that the commission is nearly fully appointed, DLS has asked FIPA to indicate why it has not included any expenditures in the 26 allowance to operate the fund. Third, on page 24, begins discussion of the Prenatal and Infant Grant Care Program. This program was created to increase access to perinatal services. The fiscal 26 allowance includes $3.3 million for the program. There is a $3.1 million funding mandate starting fiscal 2025. Language in the fiscal 25 budget bill restricted $100,000 in general funds pending a report on performance monitoring of this program. And so the information included in this discussion is coming from that report. In each year between fiscal 23 and 25, FIPPA allocated its entire annual appropriation on grant awards, and the list of grantees to date are included in Appendix 5 of this document. FIPPA has dedicated over $900,000 in grant funding in fiscal 26 to grantees who had multi-year grants that were awarded in prior fiscal years. And DLS has asked FIPPA to clarify when its next round of proposal evaluation awards will take place, given that the allowance includes $3.3 million for the program. Page 25 includes program outputs in fiscal 23 and 24, and then page 26, and it also includes performance goals for fiscal 2025. Although the outputs were included with the report did lack goals for fiscal 23 and 24, and so we don't know what those outputs are being measured against. DLS has asked FIPPA to provide the qualitative and quantitative performance metrics used in fiscal 23 and 24 to evaluate grantees' impact on maternal and child health. Despite that, DLS did determine that the report was in compliance with the budget bill language and recommends the release of $100,000 in general funds that were restricted in fiscal 2025, and will process a letter to this effect if no objections are raised by the subcommittee. And so in conclusion, DLS recommends, again, reducing the general fund appropriation in fiscal 26 by $5.7 million for tobacco cessation programs. The rest of this analysis includes a brief update on the WIC program and then various appendices that summarize reports FIPPA submitted throughout the year and summary of the major IT projects happening. I'd be happy to take any questions that you have.
Thank you so much for your thorough analysis and presentation. Do any members of the subcommittee have any questions for DLS? Okay, thank you. We'll now ask Secretary Herrera-Scott and team to join for our discussion. You can introduce whoever you wish, and you can go in whatever order you wish, and you can begin when you're settled. Thank you for joining us today.
Good afternoon, Chair Shetty, Budget Subcommittee members. I want to thank you all for your time today to speak about the Maryland Department of Health's Prevention and Health Promotion Administration budget. For the record, Laura Herrera-Scott, Secretary of Health, and with me is Dr. Nalesh Kalyanaraman, who is the Deputy Secretary of Public Health Services. We also have several other people from the team, so if we need them, we might pull them up. As always, I want to thank Naomi for her detailed analysis, and then before I turn it over to Dr. Kalyanaraman to go into the detail, I want to remind everyone it's still flu season. We've seen an uptick week over week, a 42% increase, and even though we're seeing cases go down for COVID and RSV, it's still not too late to get your flu shot. And with that, I will turn it over to Dr. Kalyanaraman.
Thank you, Secretary, and that is a great PSA. Good afternoon, Chair Shetty and Budget Subcommittee members. Thank you for having us here today. As Secretary noted, I am Dr. Nalesh Kalyanaraman, the Deputy Secretary of Public Health. Just a brief background on FIPPA. FIPPA is the unit within Public Health Services in the Maryland Department of Health that drives public health forward through strategic investments and partnerships with local health departments, health systems, community-based organizations, academic institutions, and key stakeholders. FIPPA leads vital public health programs and regulatory initiatives across all 24 jurisdictions in the state, strengthening the health and well-being of communities statewide. And so our core public health services are maternal and child health, infectious diseases, environmental health, and chronic diseases. And just some notable highlights from the past year include our work on uncovering and managing the Boar's Head Listeria outbreak. That was a national story. We were critical in actually uncovering what happened. implementing our women's health plan, and as Naomi mentioned, launching our cannabis public health campaign to prevent youth use. And those are just to name a few of the accomplishments that we have. I also want to take a moment to note, as you all know, that there are many changes being made by the federal government. It's taking a lot of time and attention on top of all our regular work to work through the uncertainty to assess the impact to our federally funded public health programming. So in light of that, I want to acknowledge our public health staff at MDH and our local health departments who advance the health of Marylanders every day and bring to life all of the programs throughout the state. And so with that, I want to thank Naomi for her analysis. You have our written responses, so I'll only highlight a few of them. And of course, we'll be happy to discuss any of them in greater detail as you wish. The first one I wanted to discuss is the, is the DLS recommendation on reducing the fiscal 2026 allowance by $5.7 million in general funds. The department respectfully disagrees with this recommendation to reduce the budget for tobacco cessation programs. You saw some of the data around our tobacco use in youth and its steady decline. That is through consistent efforts at the state and local level, and we're concerned that this proposed reduction would compromise our ability to continue to do this work. And specifically, it would compromise our ability to fund local health departments to carry out this work. The vast majority of that, 90 to 95% of that $5.7 million goes to funding the LHDs to do tobacco cessation work. The next item I wanted to touch on is around the question of FIPPA should comment on the job areas and function of the vacancies as of December 31st, 2024. In looking at our FIPPA personnel, I'm pleased to report that we've made great progress in this. As of January 1st, we have 91 vacancies, and about half of those, 44 of those, were actually newly created in FY25. And for logistical reasons, we were waiting until the beginning of the year to convert SPPs over into those positions. So 33 of those 44 have SPPs who are going to be converted. Of the other 47 pins in that total, 7 have been realigned within MDH, 16 are in active recruitment, 17 are being revised to ensure that we're efficiently and effectively delivering HIV and STI services in light of the decreased MADAP rebate revenue that we've had discussions on and that Naomi discussed. And then an additional 7 are being repurposed and realigned within the administration, primarily within the Maternal and Child Health Bureau, to support our initiatives and key programs for our women's health plan. The next item I want to touch on is the Pediatric Cancer Research Commission. This is an area where we as the department were charged with putting out grants for pediatric cancer research. A few years ago, namely in December 2023, we were ready to put forward grants, but there was a change in the function of what the grants were to go out for. So we had a range of prevention, early intervention, and research. But with legislation, that changed its function to purely research and also made us dependent on the seating of a commission, not just to be seated, but also to determine the guidelines, the oversight of grant review and the administration, and the selection of grants. So with that in mind, and the fact that the commission hasn't been seated yet, and that's in the that's in the appropriations office, appointments office, apologies, appropriations on the mind. In the appointments office, we don't believe that commission is going to be able to set all the criteria in time for us to expend funds in FY26. The last item I wanted to touch on was the prenatal and infant care grant program metrics. You have all the data for each of the years, but I just wanted to highlight what the metrics are. We're looking at how many participants are enrolled in that. Of those, how many are referred to prenatal care? How many care coordination visits we have? So those are touches with the participants. And then lastly, how many mental health referrals we have. And year on year, we've seen increases in that, and we continue to expect increases in that as that program ramps up across the state. And so with that, I want to thank you, the subcommittee, and thank Naomi once again. And I'm happy to answer any questions you have.
Thank you so much, team, for joining us today. We really appreciate the responses to the DLS analysis. We will go ahead and start with questions from members. Does anyone want to start? Delegate Heinbaugh.
Thank you, Madam Chairman. Thanks for being here. Thanks for what you do. On page 2 of your response to the DLS analysis, you mentioned, you list a breakdown of the money that goes to the local health departments for the tobacco cessation and use prevention programs. And you also add that that's going to be level funded in 26. I'm just curious, looking at those numbers by county, how you arrive at the amount by county. Obviously, it's not based on population because there's some sparsely populated counties that get more than some of the very populated counties. So is there a formula to use to arrive at that number? How do you come up with that number?
There is, and we'd be happy to share it. But in general, it's not in general. Sorry. The formula is there's a base amount of funding that each jurisdiction needs to staff up to do that work, and then beyond that, there's additional adjustment by population.
So it's based in part on how much of a problem they have in that jurisdiction, then.
Well, this is predominantly prevention, so it's less based on that. It's more just based on the population. So it's the base. Every county needs a certain base amount, and then based on your population, you get additional amounts. So the greater your population, the greater amount that you get on top of that.
Thank you. Thank you, Madam Chair.
Thank you, Delegate. Yeah, I had the same question related to this because looking at some of these, the population of some of these very tiny counties are not nearly as populated as some of the larger counties, and they have nearly identical funding coming from this. So thank you for highlighting that, sir. So anyone else have questions? Yes, Vice Chair.
Thank you so much. Can we go back to the Pediatric Cancer Research Fund for a second? So the analysis indicates that the department does not intend to expend any of the $5 million fund balance with the Pediatric Cancer Research Fund until the Pediatric Cancer Research Commission has been fully appointed. 2 of the 5 current vacancies are awaiting swearing in. Can you touched on it for a second. Can we please, can you provide any update on when the remaining 3 positions will be filled?
We'd be happy to follow up with the appointments office, but we don't. The filling of those positions is handled through the appointments office, so we're not the ones driving that. So we can follow up with you on what their timeline is on that.
That would be wonderful. Thank you so much.
Thank you. It would just be a shame to have these research dollars sitting in a fund if we can't get this commission up and running. So thank you for that follow-up. Thank you for the question. Other questions from members? Yes, Delegate McCaskill.
Thank you, Madam Chair. Good afternoon, everyone. I am going to flip to Appendix 6, page 35. My question is, and I'll give you a second. Perfect. Thank you. I'm looking down on line 10, equipment replacement. And I'm moving over to the percentage change of 27.8%. We there? Can you please provide more information about that increase in equipment replacement? It looks like about $3 million.
Sure. So that's largely due to equipment for our laboratories administration. Normally that's not within FIPA, but those grants, the ELC grants, are administered through FIPA. So it's appearing here in this budget for lab equipment for our state lab.
Okay, perfect. And then stay right there where you are. Right underneath line 11, equipment, additional equipment. I see that there's an increase of 343.5% for additional equipment that you're requesting. Can you give us more information about that?
That is the same scenario. So some of the equipment in the laboratory is replacement of existing, and some is expansion.
Okay, Madam Chair, one more. Thank you so much. Let's flip back to personnel data, page 19. I apologize. And looking at the chart, perfect. And looking at the chart on page 19 for the DLS analysis, it notes that 105 positions in the agency, within the agency, are vacant. Can you please speak to whether the proposed staff reductions in FY 2026 include elimination of some of these positions? And if so, which ones?
Sure. So as I was mentioning earlier, when we look at our files, and there's always some temporal issue of where we pull it, but in FIPA we have 91 vacancies. And we can reconcile those positions from 105 to 91 where we are now. But as I was noting, 44 of those are new positions in FY 2025, and 33 of those are going to be SPP to merit pin conversions. That
Okay.
we're waiting until January 1st to execute those conversions.
Okay.
And so those are the contractual positions that are going to be converted into those permanent merit positions.
Perfect. And then could you explain the timeline for the remaining?
Sure. So the other 47, as I was mentioning, we are in active recruitment for 16 of them. Give me 1 second. Let me just make sure I give you the exact numbers.
Sure.
So we are in active recruitment for 16 of those. 7 of them have already been realigned within MDH. 17 of those, as I was mentioning, because of how we're restructuring our HIV and STI unit to be more focused on individuals. So a large part of our organization there was around diseases, so STIs, hepatitis C, HIV. We have shifted that to be person-focused and really focusing on the prevention, early intervention, treatment, and care. And with the MADAP reductions, we're essentially revising those 17 positions, and once we've done that, they'll be posted.
Perfect. Thank you. Thank you, Madam Chair.
Thank you, Delegate. Thank you, team. I have a question related to the cigarette restitution fund, please. So in the FY26 proposal, the budget includes a $13 million reduction in funds from the CRF to cancer funding for our 2 NCI-designated comprehensive cancer centers, Johns Hopkins and Greenbaum at University of Maryland. I know we touched upon this a little bit last week, Madam Secretary, but I'm wondering if together you can share a little bit more details on the decision to zero out funding for all cancer research in our state.
So we've had to make some difficult choices, and one of the considerations we have is that for the public health work there really are no other funding sources other than the federal funding and limited state funding we have. For research, there are greater number of funding sources. We're always working with a limited budget. We talk a lot about the fact that public health has to struggle to get dollars. It typically tends to be the place where the cuts are made first. And research dollars are important, just like treatment dollars are important. But if we don't allocate prevention and early intervention within PHS, then nobody else will. Whereas research dollars can come from other sources. And so we have to make our investments in prevention as much as we can.
Got it. Okay, thank you. So we're hearing, though, that from advocates that Greenbaum is undergoing its 5-year review for NCI Cancer Center status, and Hopkins is receiving their review next year. They've expressed some concerns that a complete lack of state funding could jeopardize these designations. And losing this status could have a serious impact on clinical trials that are funded right now, as well as early academic research in our state. Have you all considered this risk in making this decision?
We'd be happy to talk to them further about what that risk is and what exactly is needed. So open to that conversation.
Thank you. Questions from committee members? Vice Chair.
Thank you so much. I'd like to go to page 21. The primary funding source for the HIV/AIDS work that you do are the federal funding through the Ryan White HIV/AIDS program and special funds through MADAP, pharmaceutical rebates, right? Is the federal funding at risk? If so, what's the department's plan to ensure the success of the program currently funded continues?
So in terms of the question of whether federal funding is at risk, as I mentioned at the top, we're waiting to see if any changes are made at the federal level. We're not aware of any at this time, but the MADAP is a different issue. The MADAP has to do with declining rebate revenue. So the MADAP is a rebate program where we get rebates from pharmaceuticals. And there have been a number of reasons for why that fund has declined over the years. One is that we were required to spend down. We were actually not allowed to carry a balance on that, but we had for many years. And so HRSA in 2017 told us we needed to spend down that balance. That's one. The second is that rebate revenues have been decreasing, both because additional organizations are able to claim those 340B rebates. Rebates are going down as medications are becoming generic. And frankly, we're seeing more people insured, so we are not the ones providing those medications. So it's a combination of a number of different forces that have decreased that MADAP revenue stream. And that's, like I said, that is independent of any federal decision.
And if I can add, the MADAP, the dollars that were in that fund, the special fund that Dr. Kalyana just mentioned, they were accrued because of the years of rebates. And then, as he said, in 2017, we were told we can't have, it can't be accrued that way. It has to go to services. So that money was spent down for additional services over and above what Ryan A, Part A and B were already paying for. So these were additional services, but core HIV services, including care coordination, still continue under Part A and Part B. And so, and as Dr. Kalyana Raman mentioned, sorry about that, all things suggest that that money will be intact, but given some of the back and forth with the federal government, right now we have the funding to continue those programs, but we're certainly watching and waiting like everybody else what programs, if any, might be at risk.
Yeah. Okay, well, thank you so very much. Sorry, Chair.
Thank you very much, Madam Vice Chair. Thank you, team. Any further questions from the subcommittee? Yes, Delegate Acevedo.
Thank you. Appreciate your testimony. Just if we could dig a little bit deeper on the HIV/AIDS funding and the services you mentioned. It's for core services. Can you just expand on that a little bit more? Because I know there's quite a bit that sort of falls under that, from counseling services to support to not just treatment, et cetera. So if there is a reduction, what's going to be impacted, or are you saying all of those services are pretty much going to remain the same?
So we can get you the list because the Planning Council dictates where some of that money goes. So we can certainly give you the current priorities of the HIV Planning Council on what gets covered under Part A, Part B. The services that were covered under the MADAP fund, those services in many cases went away, those additional services. In some cases, the entity where it was being provided found additional services either because the hospital that those services were being provided at were then subsidized by the hospital, or additional resources from other organizations were found. But in many cases, unfortunately, those additional services that are outside Part A and Part B were discontinued.
And so if you could just indulge me a little bit, when you say services outside of Part A and B, can you give
it could
one example?
Be anything from childcare to additional transportation services, so not just transportation to your medical appointments, but transportation to supermarket, let's say, to purchase. I mean, they were varied. I would want to get you the list so we were exact on what those additional services were, what those additional dollars were being used for. But I think most importantly, as Dr. Kalyana Raman mentioned, the rebates are not what they used to be because more and more people with the expansion of Medicaid are eligible for coverage. And so most HIV care is actually for insured people. And for those of you who don't remember, Ryan White was the 13-year-old that contracted HIV through hemophilia. It was named for people that were uninsured, and so it was pre-ACA, pre-Medicaid expansion. So we had a large number of persons living with HIV and AIDS that were uninsured that were then covered under Medicaid expansion. That's one. Two, for those that weren't, and we were getting those rebates, at the time, there weren't as many entities that were eligible for 340B rebates, and the MADAP program was one of them. But now hospitals are eligible for 340B. Federally qualified health centers that treat persons living with HIV and AIDS are eligible for those 340Bs. So the money or the rebates coming into that fund has just decreased over time. Again, the only reason why Maryland had so much money is because those funds had accrued. And then in 2017, HRSA said, you can't hold money like that. It has to go out to the community. So there was a 5-year plan that was actually extended up until, I think, last year. And that's when the money ran out.
Gotcha. Thank you.
Thank you so much, Delegate Ruff. Yeah.
Thank you, Madam Chair. It's Dr. Kalyanarama Raman. Sorry.
Yes, there you go.
All right, very good. Just quickly, just wanted to make sure, you're saying in your testimony today that you have no understanding of kind of the existential threats to the Kimmel Center and our cancer research centers with this, the reduction of the $13 million?
I'm not saying that I have no understanding of that, but the specifics of what's required is, I think, what I understood the chair to be speaking to, and we'd be happy to discuss specifics. But there are, there are a lot of different criteria that go into those cancer center designations, and if we're a part of that, we can have that discussion. But like I said, there's still, we still have to focus on prevention because nobody else does that, and so we have to figure out how we're going to make sure that those services continue, particularly, right? And, particularly as we see dollars are hard to come by in the prevention space.
Okay, thank you.
Thank you, Delegate. Delegate Acevedo.
I guess my question was answered. I was coming back to the research. I totally understand, wanting to focus on prevention. I would imagine that like cancer research, et cetera, all of those kind of, would play into that effort. And just curious, I mean, how do you all plan on working with whether it's UMD and Johns Hopkins so that this kind of a research and the trials that, I guess are definitely going to happen. What are you all doing, I guess, to work with them to ensure that, whether it's the cancer research, whether it's the trials, that's not something that's stopped?
Sure. So, like I said, we'd be happy to talk with them to understand the specifics of what it is that they need and what it is that they're looking for from the state. As I mentioned, and I will reiterate, we have to operate within a budget, and we have a number of programs across the state. And so we just talked about the proposed reduction in tobacco cessation efforts, right? That also poses a threat. But there's fewer people to speak up for prevention because the effects of prevention are hard to see, but we see them. We see them in our work. And just, one note, I'll note here that when we look at, and this is a paper published in a peer-reviewed journal, when they look at the gains made in cancer, 80% of that is prevention from screening and early diagnosis. Treatment is about 20% of that. And so we have to keep up, from PHS, we have to keep up our work on the prevention side of things. And so I'll reiterate, happy to have that discussion, but we need to understand exactly what is needed, and we have to make hard decisions. We can't keep doing everything that we've always done.
Sure. Okay.
Thank you, Delegate. Thank you, team. I think we'll definitely continue the conversation on this. And I know we have several folks here to testify. Seems that our subcommittee, we're done with questions for this panel, but if you wouldn't mind staying, please, and hearing the advocates, we have 8 signed up. Thank you. Thank you, Madam Secretary. Thank you, Deputy Secretary. So I'm going to go in order I have on this list. I have 3 individuals from Johns Hopkins listed: William Nelson, John Grootman, Dina Lancey. Forgive my mispronunciation. And then I'll also, I think we have 4 seats up at the table, right? So we can also have Laura Hale from American Heart join. Oh, I'm sorry, Laura Hale from American Heart. Okay, And we'll do testimony for everybody, 2 minutes each, and then we'll do questions for the full panel. You can go in any order. That's fine. You can start, sir. Go ahead.
Well, good afternoon. It's a pleasure to be with you. I'm Bill Nelson, the director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. And I have with me one of our young faculty who's greatly benefited from the Cigarette Restitution Fund investment, and John Grootman, our head of population sciences. As you all know, in reflecting the questions you just were asking, since the start of this program, I believe it's been incredibly successful. We've brought tenfold increase in funds we've been able to get from the federal government and other sources based on the investment, the seed investment we get from the Cigarette Restitution Fund. We've been able to have people start new companies that are building new ways that are less expensive to screen for cancers, germane to the previous discussion. And we've been able to start new careers, bringing people into the state or launching careers of people in the state. It's amazing, if you look at the quarter century that this program has been around, the Maryland population has grown by about 20%. It's gotten a little bit older, I think, by median age as well. And yet the total number of cancer deaths has actually decreased, specifically decreases in each of the targeted cancers by this program. It's a wonderful achievement by everyone in the state, including the health department, and all of you for maintaining this investment. So here to sort of speak in support of restoring the funding allocation to our 2 cancer centers and rejecting the BRFA requirement that we get rid of that funding. So let me turn it over to Dina, someone who's been impacted directly by the CRF funding.
Thank you for the opportunity to speak to you. I am a nurse by training, so it actually makes me a little bit different from many of the folks that receive funding to do this work. My first independent funded work came through the CRF. And it allowed me to look at the reasons why our patients are declining clinical trial participation. It's an individualized approach, and I've been able to, with the CRF funding, been able to expand that to risk reduction and prevention and screening to try to figure out what our Maryland residents need and how we tweak and modify evidence that comes from across the country to suit our residents the way they need to be met to receive the best care that they can receive.
John?
Yeah, great. Thank you. So I'm John Grootman. I met with a number of you last week in talking about CRF, and having been involved from the beginning of this program, starting with the enabling legislation, I just want to remind all of us that the wisdom of the legislature, the steadfastness of the Department of Health and others towards this program over 25 years has been transformative. In keeping in mind that Maryland used to have the worst cancer mortality of any state in the United States, we're now 35th, 36th, 37th over the course of time. We've made incredible progress in terms of tobacco control and prevention. The translation of our basic science into clinical practice and prevention has been extraordinary. And I was reflecting on the drive down here, how many cancer survivors there are in our state. There are upwards of 400,000 people who are living today who 25 years ago would not have survived their cancer diagnosis and treatment. And this is because of the existence of our 2 comprehensive cancer centers, the commitment on the part of the people of Maryland to focus on the cancer issues of Maryland. And again, the reduction of these funds is becomes extremely difficult in our ability to retain the very best faculty that we have, the very best students we have. I happen to be Dina's thesis advisor, and the support of her program and her efforts in her career transition is all due to the commitment that we've had through the CRF program. So we're grateful for that, and we hope that we can continue.
Thank you, Madam Chair and members of the committee. My name is Laura Hale. I'm with the American Heart Association. A little different for today, where I'm here in support of the funding for the tobacco control program. We very much understand the realities of the budget that we're under right now and what that means for it. One of our concerns is with the $5 million cut that's being suggested, is in that calculation, we have a concern that it's reliant on federal dollars, which we frankly do not believe we will continue to see in that calculation. We just had some concerns on that process, but also just generally want to make sure that we keep those $18.25 million of state dollars in this fund. We also have seen a rise and an increase of a product called Zen, which is very much addicting our younger high school population. And so in some of the data, it's considered an other tobacco product, so not a cigarette, not an e-cigarette, but another tobacco product. And so we are concerned as we continue to see rises in this space. The department has done amazing work, including our locals, in really addressing the needs for tobacco control. And so as you all look at these numbers and do the difficult calculations, we just ask that you all continue to support local and keep the funding in the space. Thank you.
Thank you so much to the panel. Really appreciate you all sticking within your 2-minute timeline. See, microphones are lit up. So I'll start with Delegate Acevero. I'm sorry, let's start with Delegate Ruff.
Yeah. He always concedes to me. That's how frat brothers do. Well, obviously, I have a keen interest in this topic, number one, because as a 4th grader, I can remember my mother coming home, Dr. Grubman, and telling me that she had contracted breast cancer, and knowing that she is one of the 400,000 that remain strong and survived and have been here to support me through my entire life. So thank you all for your work. I'll ask the same question that I asked of the department. Can you guys give us the specifics, and so that everybody is aware of kind of the threats to your designations and the work that you all do with this cut, this major $13 million cut?
So I would just say, and I think my friend Tafika Wanakoko will comment on this too when he comes up, which is when we submit our renewal applications to the federal government, which is responsible for our National Cancer Institute designation and the like, and we present it and are reviewed by colleagues from all across the country in a reasonably antagonistic way, I should say, but it's the game that we play. We almost every year we start out by bringing people from our state delegation, from our federal government, to talk to these people to say, the state government cares about these cancer centers, it's interested in preventing cancer and tobacco control and investing in the state cancer research effort. And this flies very, very far. I think Maryland, in my opinion, is one of the very best states for this. The only one that's even close is probably Texas, who allocates money through the CPRIT program business. But yes, we put that right out there in the competitive process, and it makes us more competitive. I think it just does. So.
And so what are, I guess, can you be more granular about the chances of your competitiveness in that process? Can you predict that based on this cut?
Predictions are hard about the future. I'm just kidding. I think the easiest way to look at it is we get a score assigned to it. If our score is higher, theoretically, they'll give us less funding. So I'd be more worried about that. I think the University of Maryland and us will compete effectively anyway because of the investment you've already made. But I think our score might be lower if people are concerned that the state isn't in lockstep with us.
Okay.
That makes sense. Yeah.
A couple more, Madam Chair, if you don't mind. Ms. Lancy, if you wouldn't mind touching base, I think I heard you say that you expanded the CRF funding that supported your work to deal with risk reduction and screening. How does that money specifically support that type of preventative work that you do?
So as an individual investigator, I've received funding to look at how we assess risk of not participating in a clinical trial. And being able to expand on that work means that I've been a co-investigator with others who learn from the things that I've identified. So as an example, I have been a member on a team that looks at tobacco cessation. So the things that I found that told me why patients and families decline clinical trials in certain regions of the city or in specific counties, we've used that information to try to figure out how tobacco cessation information needs to be modified so that The uptake of tobacco cessation supportive care services through a clinic that we run at Bayview is available, and then in turn, while we have that captive audience, to be able to relay information about lung cancer screening because those screening rates are so low.
Thank you. Dr. Grudman, we talked about earlier about how we would have to essentially amend the CRF in the BRFA, essentially removing the requirement that 50% of the funding be used for legislatively mandated uses. Can you talk to us specifically about how these specific uses have set Maryland apart from other states in cancer research?
Yeah, certainly. I mean, first point is that we're the envy of all of our colleagues in other states for the commitment that the state has had to this program in now 25 years. The second part is I've gone back to some of the original presentations I made to the legislature back when this law was being considered, and the coexistence of the focus of the CRF program to the priority cancers in Maryland, to the population in Maryland, and Maryland focus is totally in sync and lines up with the mission statements of both the Sidney Kimmel Comprehensive Cancer Center and the Greenebaum Cancer Center for focusing these monies and these resources on the problems and issues of Marylanders with respect to cancer. So that interlocking aspect of the CRF program and the mandates we received from the National Cancer Institute, that locking together is so critical in our review and so critical to how we present and manage the program. I mean, I hope that sort of answers part of your question.
Absolutely. And all that is happening in Baltimore City?
I'm sorry?
So all that's happening in Baltimore City?
Well, a lot is happening in Baltimore. We have a lot to be proud of what we've done in Baltimore City. We have a long way to go, as we all know.
I'll yield the floor, Madam Chair.
Thank you so much, Delegate. Thank you so much, panel, for your responses. Delegate Acevedo.
Thank you, Madam Chair. So I'm looking at a graph that shows the reduction in HIV and AIDS diagnosis that's sort of correlated with fundings, shift of fundings, et cetera. And I'm curious about cancer diagnosis because we don't have that graph. Have we seen an increase in cancer diagnosis in Maryland?
Yeah, actually, interesting enough, cancer diagnoses have actually increased, and that's because of increased use of screening tools. We have screened Marylanders better with PSA for prostate cancer mammography. One that lags behind, we believe, is the CT scan screening for lung cancer. So the diagnoses have actually gone up since the beginning of the program, but the deaths have gone down. So the other way to look at it is if you're diagnosed with a cancer today, 3/4 of the people live at least 5 years. Back when it started, it was only about half. So strangely enough, diagnoses have gone up because we're detecting more of the cancer at an earlier stage.
Gotcha. Thank you. Thank you.
Thank you so much, Delegate McCaskill.
Thank you, Madam Chair. Thank you for sharing that 400,000 patient survivor. It gave me chills, so it's really good to hear that. I'm shifting a little bit to what's happening most recently every second on the federal level. Okay, so back to predictions. So you've been doing federal funded research for quite some years, correct? So how concerned are you about what's happening at the federal level? More specifically, how concerned or how much confidence should we have that Maryland will be able to continue should there be any major shifting?
I think that our state and our two cancer centers are very good and very resourceful. We will figure out some way to continue to make whatever progress we can. The things that we're very worried about at the moment are related to diversity, equity, and inclusion, particularly among trainees, students, and our workforce, our faculty, because we have created, as the University of Maryland, a number of pipeline programs, a number of programs to seed people, including with the Cigarette Restitution Fund, bring people in the state, get them started. And the way those are described for the federal government and the way some of those programs are activated in the federal government worries us. The second one is a cousin of that, My understanding, this being the legal scholar that I'm not, so keep that in mind, my understanding is that when we think about how we reach out to in the state, the entire community, people of color, people of Asian heritage who don't speak our language, when we reach out to these people, that dedicated programs might also come into this target of the people who want to get rid of DEI throughout what the federal government funds. And that, at the moment, is our biggest collection of worries, I think, are in that space, if that makes sense.
Thank you for sharing. Thank you, Madam Chair.
Thank you, Delegate. Further questions for this panel? Seeing none, thank you all for your work. Appreciate your testimony. We'll now call upon the next 4 witnesses, please. I have Alex Casper from the American Lung Association, Philip Ateto, Dr. Owikonoko, and Lance Kilpatrick from ACS-CAN. You can go in any order you wish. As soon as someone sits, they can begin, and we'll do 2 minutes per person, please, and then questions for the panel. Thank you so much for being here.
Thank you so much, Madam Chair, and thank you all for the subcommittee members. I'm Taufik Owenikoko, the Executive Director for the Greenbaum Cancer Center. I want to thank this committee and the state of Maryland that the foresight that this body had 25 years ago to mandate a portion of the CRF be allocated to support our academic health centers has actually borne fruit. And how do we measure that? Is when we get this support from the state, we use this to build the infrastructure and create the environment that allows us to attract people from outside the state to come and work in Maryland and take care of our patients. This has resulted in tangible progress that we've made. That Maryland has gone from the worst in the nation in terms of cancer outcomes in the 90s to the 12th best in the nation by 2021, based on CDC data. This is reflected in more than 200,000 patients that we have treated at Greenbaum and our affiliates. More than 130,000 of those 400,000 survivors that you heard about were actually patients who received cutting-edge treatment at Maryland and our affiliates' locations. This is in terms of access to clinical trials for cutting-edge treatment of tomorrow that we bring to patients in Maryland today. And we do have patients who would attest to this. This is also in terms of economic impact. We do not use the CRF money to fund the research. We use that to create the environment to attract very, very competent scientists to come and work in Maryland. In the past 20 years of CRF funding, we've brought about $1 billion into the economy of Maryland through federal funding and pharmaceutical research being conducted by our faculty members across University of Maryland, Greenbaum Cancer Center. And you get similar results from Sidney Kimmel Cancer Center. The impact that CRF going away would have on us is that we can no longer maintain that environment that we create to attract competitive candidates to come and work in Maryland, who can then go out and get the federal fund to help us do this work. Access to clinical trials is going to be impacted, and I want to emphasize 80% of patients going on clinical trials or getting treatment at Greenbaum Cancer Center come from Baltimore City and 10 additional counties across the state of Maryland. So we serve the entire state. If we don't have this access, we are going to lose all this benefit that we've had. And this is why we are requesting the subcommittee to support us in making sure that we continue this support and also make sure that long-term, we do not allow the buffer statement to stand. Thank you.
Thank you, Doctor. Thank you for your testimony and for helping us understand the stakes. Thank you.
Cool. Hello, my name is Phil Ateto, a lifelong Marylander from Severn, and I've been living here in Annapolis for 17 years. I'm grateful to be testifying in front of my own delegate, as well as some legislators I know are champions of the people. After a healthy, active youth playing sports and working out, I was diagnosed with a rare blood cancer called multiple myeloma in August 2010. I went through the standard chemotherapy treatments. Some didn't work, others kept the cancer at bay, anywhere from 6 months to 2 or 3 years. I found that cancer treatment's like a game of Frogger. Sooner or later, the treatment you're getting is gonna stop working, and you better have somewhere else to jump or you're drowned. In this case, the jump being to a new medicine. After around 6 years of different treatments, I ran out of options, so I signed up to be a patient in trials my doctor ran at the University of Maryland Greenbaum Cancer Center in Baltimore. Some worked, some didn't, to varying degrees. During these trials, it was immeasurably important for me to be able to stay at home and access treatments relatively close by. Home is where my community and support network are, which are crucial to anyone going through difficult times with health or otherwise. No person is an island, and who wants to live in a hotel during such a stressful time while going through treatment with all the various side effects? And if I'm being honest, I want to be home around my cats who help bring me comfort and joy. Also, I'm mostly on a fixed income, so traveling out of state for treatment isn't affordable and therefore not an option, as my insurance doesn't cover out-of-state treatment, as trials cover the drugs, but often not the health care provided around it, which is paid for by my insurance. I found healthcare is expensive even with good insurance like I have, and without the cost of treatment would be completely unaffordable. Take this as a plug for a single-payer healthcare system. I hear it said often that a budget is a statement of values, so when a line item that is crucial to my survival and well-being is completely cut, the message it sends to me is that my continued survival is of zero importance. With all the rollbacks and cuts of the new presidential administration, I felt safer to be in a state with a governor who campaigned with the slogan, "Leave no one behind." But when I see a line item that is crucial to so many of us zeroed out, it shows me that I don't count as someone. I hope you'll be able to see my humanity and the value cancer patients still are to our community as others do. I urge you to show Marylanders like me that our lives and well-being are not expendable by funding the budget line item for cancer treatment research and trials as much as possible. I understand that the budget shortfall must be addressed and cuts must be made, but surely this doesn't have to be achieved by abandoning vulnerable people in our communities.
Thank you,
Thank
sir.
you.
Thank you so much for being here today, and thank you for sharing your story. We appreciate it. Go ahead.
Madam Chair and members of the subcommittee, thank you for the opportunity to make comments. My name is Alex Casper, and I'm the Director of Advocacy for the American Lung Association. We understand the state is facing difficult financial situation and appreciate the committee's hard decision in front of them. We wanted to specifically address funding for Maryland Department of Health Tobacco Control Program and express our concern regarding the proposed reduction of $5.7 million and reducing the funding to the $18.25 million outlined in statute. But we wanted to provide some additional information for consideration as you move forward with the decision process. According to the Lung Association's State of Tobacco Report Card, Maryland was named one of the most improved states because policies passed and supported by the General Assembly, including significantly increasing the tobacco tax on tobacco products and modernizing the way tobacco is sold and laws are enforced in the state. The report also recognized the value of funding for tobacco prevention and highlighted that Maryland, even at $23 million, Maryland is woefully underfunded. According to the CDC best practice, we should be funding the program at $48 million. Keep in mind that part of the $23 million is federal funding, and we have experienced in the last couple of weeks that is uncertain. The number one thing we can do is prevent people from initiating tobacco use and then help them quit. The $5.7 million that is proposed to be cut is doing just that. It is supporting local health departments, if you heard. In recent national data, 2.25 million kids are using an electronic cigarette. In Maryland, 15.6% of high school students use a tobacco product. You heard about the new products that are entering the market that are appealing to children. Smoking attributes to 490,000 preventable deaths nationally and 7,400 in Maryland, and $2.7 billion in healthcare costs in Maryland. Now is not the time to take away important efforts, especially as we see youth rates remain alarmingly high. We have seen that when we reduce resources, rates increase. We know you face difficult decisions ahead, and we strongly support the $18.25 million that is outlined in statute, but hope that you take some of the information that myself and my colleagues will provide in addressing the 5.7. Thank you.
Thank you so much. Mr. Kilpatrick.
Madam Chair, Madam Vice Chair, members of the subcommittee. For the record, my name is Lance Kilpatrick. I'm the Government Relations Director for the American Cancer Society Cancer Action Network. Let me, at the risk of being redundant, let me try to shorten my remarks to two topic areas. First of all, as Dr. Nelson and Dr. Owanekoko have pointed out, this funding is very important for cancer research. What the subcommittee may not know is that going back to the Ehrlich administration, never has this funding been zeroed out before. Never. So I would just like to let that sit for a moment and then move on to the second topic. The second topic is what my colleagues have pointed out regarding the tobacco prevention and cessation funding. As has been said, $3.5 million, according to the DLS, right, is federal funding. I don't think we have to convince anyone here that what's going on right now calls into question the funding coming forward to the states. If that were the case, and we reduced it to the statutory minimum of 18.25, but we are including the federal funding that may not come, we actually go below the statutory minimum going forward. Bottom line is that these funds we're talking about are investments. They're investments in the health and well-being of Marylanders. And we all know that it takes money to get a better return on investment, and that return on investment is the better health outcomes for all Marylanders, regardless of age. So I strongly urge the subcommittee to advocate for the restoration of these funds going forward, and I thank you so much for your time.
Thank you so much, panel, for your testimony. I'd like to start with one question, please, and I'm going to direct it to Dr. I will butcher your last name, and I'm really sorry. Doctor, please share with us, if you know, so can you tell us, because of the NCI Cancer Center designation, how much money the University of Maryland is able to bring in from federal resources?
So in 2024, we brought in $119 million that funded our research that we do.
$190 million?
$119 million.
19,
And for our designation, which is coming up 2026, part of what we are assessed by is the level of support we get from the community where we serve, including our state and our counties. And that is part of what we write in our presentation to the site visitors. So this is a valuable, well-appreciated program for the state, and this is why we get this level of support. And this is why our neighboring state, like state of Virginia, provides $25 million to each one of their 2 cancer centers. North Carolina provides $60 million per year to Lineberger Cancer Center. So this is the type of support that we all have to show in order to keep the designation. And the designation is not just that you're getting something and somebody's patting you on the back. It actually makes our life easier because it helps us to attract people to work with us, both within the state and outside the state. And part of that, what that also does for us as comprehensive cancer centers, is that we are also mandated by that designation to also focus on prevention and working in the community, not just within the 4 walls of our institutions.
Thank you. And does the investment in cancer research funding in our academic institutions generate any private sector benefit?
Yes, there are private sector benefits to the research that we do. Part of what we do when we take things from the lab is you don't want it to sit in the lab. We want it to get into the clinic. Oftentimes, institutions on their own do not have the wherewithal to make things, make new drugs to get them into the clinic. So you have to partner with public-private partnership to get that going. Some of our faculty members may have their own side of where they go out and raise funds in order to develop this agent to become treatment that we can now administer to patients in the regular environment, yes.
And is there a dollar value of private sector economic generation that occurs because of our investments in cancer research and your NCI designated cancer status?
I do not have that number off the top of my head. I can get that back to you. But overall, when we look at the total amount of money that we brought in, both federal and private, over the past 20 years at Greenbaum alone, it's more than $1 billion. So when you look at return on investment for us, it's more than tenfold return on investment that we make through CRF.
Thank you. That's very helpful. Further questions from the subcommittee? Okay. Thank you so much, panel. Thank you, advocates, for your testimony. Thank you for being here. That concludes our budget hearing for the Prevention and Health Promotion Administration. We will now switch to the Office of Deaf and Hard of Hearing. We'll start with our DLS budget analysis presentation, and I may have to step out briefly during this discussion, and if so, Madam Vice Chair will take over for my place. So thank you. You may begin when you're ready.
Thank you, Madam Chair. Good afternoon. I am Natalie Andrade with the Department of Legislative Services, here to present the Fiscal 26 allowance for the Office of the Deaf and Hard of Hearing. On page 1 of the analysis, you will see that the fiscal 26 budget increases by 111,000 or 10.5%, bringing
Miss,
the
can
total.
you speak up a little? It's a little hard to hear. There's noise behind us.
Sorry.
And it's okay. Thank you.
I will repeat it. On page 1 of the analysis, you will see that the fiscal 26 budget increases by 111,000 or 10.5%, bringing the total to $1.2 million. Turning to page 2, you will find an update on the implementation of legislative priorities. Chapters 442 and 443 of 2024 establish a work group of the deaf, blind, and hard of hearing, which the office staffs. The work group held its first meeting in November 2024 and has scheduled 7 meetings for 2025. The office received an additional $10,000 in general funds for interpretation services to support accessibility for deafblind participants. On page 3, Exhibit 1 provides a breakdown of the fiscal 26 allowance. Personal expenses account for 78% of the total budget, with cost allocations making up 7% and sign language interpreting services comprising 6%. These interpreting services support both internal operations and public meetings. Turning to page 4, Exhibit 2 outlines the key changes in the budget. The increase of $111,000 is primarily driven by personnel-related expenses, including salaries and benefits that account for $74,000 of the growth, while $13,000 support expanded outreach efforts, including town halls and engagement programs for marginalized communities, such as deaf and deafblind interpreters and interpreters of color. On page 5, in the personnel section, you will see that as of December 31st, 2024, the Office of the Deaf and Hard of Hearing had 4 vacant positions. The fiscal 25 budget allocated 4 new positions to the office, 2 through a proposed efficiency and 2 in the fiscal 25 allowance. This included a deputy director, an outreach and interpreter manager, a compliance officer, and an administrative assistant. The outreach and interpreter manager positions were filled in July 2024, and the administrative assistant position was filled in August 2024. However, the deputy director and compliance officer positions remain vacant, along with 2 additional roles, a policy manager and a public relations officer. The office has indicated that its current priority is filling the deputy director and compliance officer positions before advertising the remaining vacancies. So the Office of the Deaf and Hard of Hearing should comment on the status of the vacant positions, including the agency's current recruitment efforts and any challenges it may be facing in filling these roles. Now jumping to the key observations section. On page 6, you will find an update on the State Board of Sign Language Interpreters, which was established under the Maryland Sign Language Interpreters Act. The board has made progress in developing licensing regulations, which are currently under review and awaiting publication in the Maryland Register. A licensing portal has been developed and will be launched once the regulations are finalized. Regarding the board composition, as of January 2025, the board consists of 7 seats, 5 of which are filled. The remaining vacancies include representatives from the Potomac chapter of the Registry of Interpreters for the Deaf and a general community representative. The office is collaborating with the Appointments Office to identify candidates for the missing positions. On page 7, discusses the application fees and complaints processes. The board has structured fees to balance accessibility and sustainability, with individual licenses set at $150 and provisional licenses at $300. Additionally, the office has developed multiple channels for handling interpreter-related complaints, including collaboration with Registry of Interpreters of the Deaf and the Department of Justice. Finally, to ensure interpreter misconduct is addressed appropriately, multiple channels are listed here in the analysis for filing complaints. Finally, on page 9, the DLS recommendation is to concur with the governor's allowance. And with that, I conclude my presentation, and I'm happy to take any questions that you have.
Thank you so much. Any questions for our analysts? Seeing none, thank you. We'll now call up our ODHH panel. Hello.
Greetings, Chair and members of the subcommittee. It is an honor to be here on behalf of the Governor's Office of the Deaf and Hard of Hearing as the director. It has been a true privilege to work with the Moore-Miller administration to support the deaf, deafblind, and hard of hearing communities in the state of Maryland. I would like to thank our legislative analyst, Nathalie Andrade, and her work with our office, and her understanding of what we do for the deaf, deafblind, and hard of hearing community. I'm very grateful for the hard work of my team that I have with me, Diamond, Laura, and Tanea. This fiscal year has been about maintaining communication with the deaf, deafblind, and hard of hearing community. And we did this through our town hall meetings with and without our advisory board. The Maryland Advisory Commission on Deaf and Hard of Hearing, MACDHH. Additionally, we have helped keep the community informed on any upcoming issues in regards to the licensure with the State Board of Sign Language Interpreters meetings. More recently, ODHH helped facilitate deaf-blind, hard of hearing work group. ODHH needs to comment on the current recruitment efforts and any challenges that we may face filling the roles that we have vacant. Under my leadership, the office is currently ongoing a reorganization. The office has 4 vacant positions, 2 of which are in the process of being filled, which are the deputy director and the compliance officer. Those 2 positions are in the final interview stages. The remaining vacancies are the policy manager and the PR position. Those positions will be actively recruited once the deputy director and compliance officer positions are filled. On page 9 of the operating budget, ODHH does concur with DLS's recommended actions. And then my response when it comes to filling positions, I wanted to go ahead and let you all know about that. So because we are ongoing a restructure with the new administration, we have a new administrative assistant and the interpreter coordinator that have already been filled. The interpreter coordinator manager has already been filled. Outreach interpreter manager, apologies, that was the interpreter's error. The new administrative assistant have been learning their roles and responsibilities, as well as additional responsibilities, because we have a small unit. The 2 vacant positions, the deputy director and the compliance officers, are in the process of being filled. There were 15 applicants for the deputy director position and 29 for the compliance officer position. The remaining vacancies we have are for the policy manager and the public relations position. The policy manager is responsible for legislative action within the office, any legislation that may impact us, and research, so things of that sort. The PR position is responsible for creating and maintaining a positive image for the organization through social media, websites, emails, things of that sort. The delay in filling these roles are due to scheduling, holidays, and the lack of an MS-22 job description. Those were needed in order to create the positions. The roles are very complex, and the demands are high. The director's skill set that is needed, the skill set needed for those positions need to be taken into consideration. I would like to open it up for any questions.
Thank you so much for your presentation and for your thorough response to the DLS analysis. I need to apologize and now give the gavel to the Madam Vice Chair to take over on my behalf. I have to step into another meeting, but it's very lovely to see you, and I look forward to our continued partnership and work together. Thank you.
Likewise.
Thank you so very much. Delegate Acevedo.
Thank you, Madam Vice Chair. Director DeBerry, thank you so much for your testimony. Wanted to go to page 4, where in the DLS report it indicated that the agency has indicated plans to enhance community engagement by hosting town halls and other programs aimed at marginalized communities, including deaf interpreters, interpreters of color, and deaf-blind interpreters. As you know, Director, there's American Sign Language, and then there's Black American Sign Language. And I'm curious, when you say increasing the number of interpreters of color, is there any intentionality in terms of who you're working with to do that? I know that there are some historically Black colleges and universities, one that I'm a proud alum of, Bowie State, that do have programs where they train in American Sign Language. And I'm curious if you could just expound a little bit more on what your agency is going to do to increase the number of interpreters of color, and specifically around, just that culturally competent aspect of Black American Sign Language, and making sure that those who are deaf and hard of hearing and are members also of communities of color, that they are not left out or left behind when we talk about increasing the amount of interpreters of color that are available in our state. Thank you.
Thank you for that question. Thank you, sir. So we would like to maintain our current priorities by the current administration, and you are right, we do not want to leave anyone behind. Congratulations to being a successful graduate of an HBCU. That group is really a special group to my heart. Just being who I am, that's part of our daily lives. And you are right, it is hard to identify the interpreters of colors in the state. When the law was established, that became a huge responsibility for our office. which means that we have to hear from them. They are telling us what would work for them. And that's what we're doing. We're bringing that conversation to the table and making them feel comfortable. Many times in a role, such as a director, we look for where our interpreters of color are, where are our Black deaf interpreters, where are our deaf-blind interpreters of color as well. There are some things that are lacking with that in terms of certification. Sometimes the certification they can't afford. And that is where, with our interpreting licensing portal, when that does launch, we would like to take some funding from there to help with our program, where they're able to apply for a grant to help pay for them to take the test. We are also planning on establishing a study group with them. We want to have a regular program established with them, and we recently sent out a survey. And we have the results of that survey. That is going to help us know what we need to do moving forward with this group. We are still in the creation phase with that. Is there anything that you wanted to add? Thank you, Director. No comments. Thank you.
There we go. Thank you so very much. Delegate Ruff.
Thank you, Madam Chair. And good afternoon, Director DeBerry. First, I have to say that the locks and frames combination is fierce. Killing it. You're killing it.
Thank you. Thank you so much.
I wanted to ask about
Amazon and Macy's.
I wanted to ask about the outreach efforts that you are enhancing. First, can you just identify for us in the pie graph on page 3 which category the outreach expenses falls in?
Okay, so taking a look at the pie chart, there is a portion that says other expenses.
Okay.
That's where it would be.
Understood. So
Thank you for your question.
Considering the expansion that you all, the enhancements that you are making towards outreach, could you give us a flavor of the outcomes that you are seeing from these enhanced efforts? And can you also let us know whether the existing resources in your department are sufficient to meet the goals that you have for your enhanced engagement and outreach?
Thank you, sir, for your question. This is going to be our first time doing this. So I am trusting my team with this. And with the new staff coming in, I knew I couldn't do it alone. This is something that we had to share the responsibility. That's the whole purpose of having the deputy director and the compliance officer and the outreach manager. I think really we are all playing a key role in that, plus hearing from the board as well. So I think to answer your question, I think we will be okay. We're not asking for a lot. But at the same time, we are not looking to ignore or exclude anyone. So we are looking to work closely with department agencies and work with local organizations as well, like NAOBDC, the Potomac chapter of the Registry of Interpreters for the Deaf, and the National Alliance of Black Deaf Interpreters, and the Potomac chapter as well. Those chapters are really motivated and ready to work with us. They've been waiting for a long time to share their stories and get the support that they need.
Thank you.
You're welcome.
Delegate Heinbaugh.
Thank you, Madam Chair. Thank you for what you do, first of all. Secondly, I have to assume that with the population generally getting older, that attributes to a bigger population of people with a loss of hearing. And I've read a lot of studies that talk about how the loss of hearing can affect your cognitive skills and Alzheimer's and dementia and all that sort of thing. So with the aging population, if my assumption is right, with the aging population and more people that have a hearing loss, and all these studies that show a relationship between hearing loss and memory loss, how will you address that in your outreach efforts? Will that trend, if it's correct, will that trend cause you to adjust or make changes to your outreach efforts?
Thank you so much for your question. I am also aware that when hearing loss does happen, it impacts the lives of that person moving forward. And so it's best to be collaborative with deaf culture, which means that it's a good idea to learn ASL. What helpful tools are out there in order to continue to be as independent as possible, because that's what the goal is in the state of Maryland. We want Marylanders to be independent, but we also have to work very closely with the Department of Aging in that aspect, and we have been doing that. We have been working closely with them through our senior call check program. That program is looking for people who have hearing loss, or what is the best approach is for them. It's not a one-size-fits-all sort of call. We have to see what they are looking for, what works best for them, which includes people in the deaf community. And we find that many people who have hearing loss, they have the same answer as people in the deaf community. They want somebody on the phone when somebody calls them. So that's interesting data that has been shown. And I've been working with vendors, and it's important to work closely with the Department of Aging and the Department of Disabilities as well. And I believe we have great partnerships.
One follow-up, if I could, real quick. So with all the studies that show that a loss of hearing leads to or contributes to a memory loss, are you aware of any initiatives at, I don't know, the federal level, I doubt at the state level, to provide people that have hearing loss with hearing aids or devices that could help them hear better?
There's the TAP program. I don't know if you want to comment on that. Yes, I can. Is it?
Asking for a request to use her voice. Hello. Thank you for your question. We did recently meet with the Maryland TAP program, and they have shared with us a lot of their new initiatives to supply people who are interested in many disabled devices, but hearing aids as well. Their loan program, they have a program where someone can come into their facility, try their hearing aids, and have it for about 30 days. And if they like it, they have the opportunity to purchase it. They also have referrals to other programs where you can get a pre-owned device for free. You would just have to fill out an application and match their qualifications. And sorry, I didn't introduce myself. My name is Diamond Holbert, and I'm the administrative assistant for ODHH.
Thank you. Thank you, Madam Chair.
I also would like to add onto that. With the Maryland Department of Aging, they do have a program, a longevity program. And that really sparked us because we noticed that, people are living longer. But how can we continue to better support them? And yes, that's the reason why we have to share all of those devices. We're working with the Accessibility of Maryland. They have those devices that people in the deaf community who want to use those devices are able to. So it's important to stay knowledgeable and continue those partnerships.
Excellent.
You're welcome.
Thank you. I have a question. I don't want to step on anyone else. Can we turn to page 6, please? Regulations and licensing portal and database. On page 6, the DLS analysis, it mentions that licensing portal is ready for public use, but that it will not be launched until the regulations are officially posted. When do you expect the regulations to be finalized?
Thank you for your question. So the regulations are ready. They are sitting in the AELR. They are ready to be posted with COMAR. So right now, I am working very closely with my team in order to share an economic impact notification with that. So that is some of the behind the scenes work that we are doing in regards to that. But besides that, we can't hold the portal any longer because we do have a contract with an external contractor who is working with Do It. So that means that the portal will launch sooner than we actually anticipated. So we are looking at in the next 45 days. So we're going to have a 30-day trial, and then at 45 days, we will have that released. We can't continue to hold on to it because of the delay in the regulations, which means that the interpreters will be able to apply on the dashboard, and they can continue on that aspect, but the license is on a holding stage right now because once we are done with that 45 days, we do have to have a 30-day period where people are allowed to comment on them. And then it has to go back to the board. They have to look at them again to see if there's anything that needs to be revised. So we're looking at another possibly 3 months.
Thank you so much. I'm glad we were able to get that on the record. Does anyone else have a question? Any committee members? No? Thank you, Director, and thank you to your team. I appreciate it.
Thank you so much. It's an honor.
Right. Okay, so we don't have any other witnesses. Okay, we will be moving on to our DLS analysis. Natalie Andre. And whenever you are ready, please proceed.
Thank you, Madam Vice Chair. Good afternoon again. I'm Natalia Andrade with the Department of Legislative Services to present the fiscal 26 allowance for the Maryland Department of Disabilities. On page 1 of the analysis, you will see that the fiscal 26 budget increases by $4.1 million or 32.6%, bringing the total to $16.5 million. This increase is primarily driven by an additional $1.6 million in special funds and $2.4 million in federal funds. The additional federal funds result from new grant awards, while the special funds reflect increased demand for telecommunication access Maryland programs. On page 3, Exhibit 1 provides a breakdown of the fiscal 26 allowance. As you can see, personal expenses account for 33% of the total budget, with the Office for Individuals with Disabilities receiving the largest share of personal funding at $2.6 million. Other significant portions of the budget include the TAM programs with 26% of the budget and the Attendant Care program with 8% of the budget. Turning to pages 4 and 5, Exhibit 2 outlines the key changes in the budget. And as you can see, the $4.1 million increase is largely driven by $2.2 million in federal funds, supporting 2 new federal programs, the Development of Inclusive Futures and the Improving Children's Assistance Program. Additionally, $1.2 million in special funds is allocated to meet growing demand for accessible telecommunications equipment for Maryland's deaf and deafblind communities. On page 7, in the personnel section, the fiscal 26 budget includes the conversion of 1 contractual position at MDTAP program into a regular position and a net increase of 3.5 contractual full-time equivalent positions. These new positions will support disability employment initiatives, Maryland TAP operations, and administrative assistance for the TAM program. The 24 JCR requested Maryland Department of Disabilities to report on 2 vacant positions and recruitment efforts. The agency faced challenges filling the advanced accountant role due to market competition and is using a contractual hire while planning a 3rd recruitment. The Developmental Disabilities Council attempted recruitment but found no qualified candidates and is considering restructuring the position. Both positions remain vacant as of December 31st, 2024. Now jumping to the key observations section. On page 8, there is a discussion of the Universal Services Trust Fund expenditures. And on page 10, Exhibit 3 provides an overview of the Universal Service Trust Fund expenditures, which increased from $2.7 million in fiscal 2019 to $4.9 million in fiscal 2024. This increase is primarily due to expanding Maryland Relay and the Maryland Accessible Telecommunications Program, as well as introducing new initiatives like the Senior Call Check and Communication Facilitator programs. Maryland-related expenditures alone rose from $1.4 million in fiscal 2019 to $2.1 million in fiscal 24, reflecting both higher relay service demand and contractual cost increases. The MAT program's budget nearly doubled from $400,000 in fiscal 2019 to $965,000 in fiscal 24, driven by increased adoption of telecommunications equipment among Maryland's disability community. On page 11, Exhibit 4 presents projections of the USDA balance, showing that at the current surcharge rate of 5 cents per communication service bill, the fund will run a deficit beginning in fiscal 26, with a projected shortfall of $860,000 by the end of fiscal 27. If no adjustments are made, the fund's deficit will continue to grow, reaching $5 million by fiscal 2029. A budget amendment submitted in December 2024, which is not reflected in the fiscal 25 working appropriation, added $2.5 million in TAM program funding, increasing Maryland Relay's budget from $800,000 to $2.2 million, and matched from $700,000 to $1.3 million. These adjustments were necessary due to a higher than expected demand for accessible telecommunication equipment and slower than expected reductions in Maryland Relay traffic, particularly among older adults and rural residents. So the Maryland Department of Disabilities should comment on whether it anticipates revising the timing of its recommended surcharge increase to address the fund's earlier than expected depletion, and what alternative measures are being considered to stabilize the fund. On page 12, key observation 2, present a proposal to create a new office of disability employment advancement and policy within the agency, as introduced in the 2025 session. This office will oversee the Maryland as a Model Employer Initiative, which will focus on inclusive recruitment, training resources for state agencies, accessibility improvements, and workforce data collection. Maryland Department of Disabilities is expected to integrate these efforts within its existing structure and evaluate the initiative's impact. So the agency should clarify how it will align this new office with its current program and whether additional resources will be needed for successful implementation. And to conclude, on page 14, the Department of Legislative Services recommends to concur with the governor's allowance. And with that, I conclude my presentation. I'm happy to take any questions.
Thank you so very much for your thorough analysis. Does anyone have questions for DLS? Thank you so very much. All right. The Secretary and team, whenever you're ready, you can begin when you are settled. Thank you.
Thank you. Good afternoon. Good afternoon. Vice Chair and members of the Health and Social Services Subcommittee. For the record, I'm Carol Beatty, and I am the Secretary for the Maryland Department of Disabilities. We want to thank you for this opportunity to appear before the committee today as you review the proposed operating budget for our department for fiscal year 26. And we always would like to acknowledge our analyst who does a super job. So thank you so much. With me today at the witness table is our new Deputy Secretary, Ann Blackfield, and our Assistant Secretary, who's been with the department since the beginning, John Brennan. And in the audience today, we have Jade Gingrich, who is our Director of Employment and Transition Policy. And you have our written testimony, and so with your permission, I will go to the issues and address those. Thank you. We'll summarize them. So we've been asked to comment on whether MDOD anticipates revising the timeline of our recommended surcharge increase for the Universal Services Trust Fund due to earlier than predicted fund depletion. And I want to thank our analysts for bringing this up and giving us an opportunity, and the subcommittee for giving us an opportunity to address the timing of the surcharge increase to stabilize the USTF. So in an effort to do just that, we requested and received a surcharge increase to 9 cents from 5 cents beginning fiscal year 26 from the Public Service Commission. This surcharge adjustment, along with a requested and received FY25 increase in our spending authority, will address the fund's earlier than expected depletion and bring it back to the recommended level of 1 year of operating costs. In addition to the surcharge increase, we are implementing cost savings measures to further stabilize the funding source, which we've outlined in our written testimony. And we've also been asked to comment on Senate Bill 433, House Bill 502, which is legislation that was requested by the governor this year to establish the Office of Disability Employment Advancement and Policy at the Department of Disabilities. And Delegate Ruff, we appreciate so much your co-sponsorship of the House bill. The work of this proposed office will build on the coordination function that we have provided to increase employment opportunities for people with disabilities since the establishment of the department 21 years ago. This coordinating function is clearly defined in our statute that created our department. And this office will oversee what is referred to as the State as a Model Employer Initiative, or we shorten that to SAME. State government plays an important role in the advancement of the recruitment, hiring, retention, and advancement of people with disabilities through their own employment policies, thereby serving as a model for the public, private, non-public, and local government and municipality sectors. Maryland state government has really had quite a good long run as a leader in SAME, with our disability hiring preferences, with the special options eligible list, the pre-pandemic and the post-pandemic telework policy, and the DOORS Quest program. However, more needs to be done to make sure that state employment is a realistic goal for qualified individuals with disabilities. The best work can't be done in silos, and so a coordinated effort situated or seated within a state department that's charged to work collaboratively across state agencies is planned. This effort will be tightly coordinated with our other state agency partners whose work centers on increasing employment opportunities. These include DBM, their Office of Personnel Management and Benefits, the Department of Labor, the Department of Health, including the Developmental Disabilities Administration and the Behavioral Health Administration, and MSDE, the Division of Rehabilitation Services, or what we refer to as DOORS. These and other partners were involved in the planning of this initiative and are prepared to support this work should the legislation pass. The new office will work with state agency partners to provide training and technical assistance and identify vacancies and potential job seekers. At the same time, we will work with the community itself to do outreach and provide support to individuals with disabilities interested in state employment. We currently have a Director of Employment and Transition Policy, and her work is the foundation upon which this office will be integrated. The legislation that establishes the office requires no funding for FY26 and will be absorbed within the department's current workforce. We will use FY26 as a planning year with our other state agency partners. I'm very grateful that both Governor Moore and Lieutenant Governor Miller's for their leadership on this issue of great importance to the disability community. Delegate Heinberg, I wanted to just address your question about the link between hearing loss and memory loss. And our program, the Maryland Assistive Technology Program, was mentioned in the answer. I want to let you know that we have recently received a federal grant from the Administration for Community Living, which is a part of HHS. And it is specifically to increase the use of technology for hearing loss, like hearing aids and so forth. So if you'd like, we can follow up with your office and provide some information. So in closing, we respectfully support the recommended action to concur with the governor's allowance, and we'll be glad to take any questions that the subcommittee members might have.
Thank you so much. I see folks reaching. Thank you so much, Secretary. Delegate Heinball.
Thank you, Madam Chair. Thanks for your presentation in response to the DLS study. If you look at page 9 of the DLS analysis under the senior call check program, it mentions that there's been relatively slow growth in subscribers to it, but then it also mentions that there's been a pretty significant increase in expenditures from, I think it was 58,000 in 2019 to 442,000 in 2024. I just wonder how What's that attributable to, or how is that money used, or how did it contribute to your mission?
So thank you for the question, Delegate. Specifically, you're asking about the Senior Call Check Program?
Yes.
Within,
I'm sorry.
all right. So there are 5 programs that are funded through the USTF fund, and 4 of them are administered by our department. And those 4 are primarily programs that attend to the needs of and the support needs of people that are deaf and hard of hearing. The Senior Call Check Program is a program that's administered by the Department of Aging. And so I will ask our Assistant Secretary if maybe he can take a stab at that question.
Sure. So the main increase from 2019 to 24 that's highlighted in the analysis is due to the establishment of the program. In 2019, it was just getting established. What the Senior Call Check Program does, I think there's roughly between 1,500 and 2,000 participants. Eligible seniors are able to get a call to check on their well-being, and if there isn't a response, they get a follow-up. And so the expenditures for the program relate to marketing and outreach, staff that the Department of Aging has assigned to support this program, and then a call center that they operate. Does that answer your question?
Thank you, Madam Chair.
Thank you so much. I actually have a couple questions. Can we go to Appendix 2, please, page 16 of the analysis? It shows the various line items of the budget request that will see changes in FY26. Can you please provide information on a few of these? Sure. So the 129% increase in technical special fees.
Oh, yes, I'm sorry. Yes.
Sure. That relates to contractual employee positions, and as you can see from the analysis, we had a net increase in contractual positions primarily related to the federal grants that we received. So those are federal dollars, and they are to hire contractual staff to help provide support and grant management for the 2 grants that we got that are roughly $10 million over 5 years.
That's for the technical special fees, the 129%?
Correct.
Okay, so then the 67% increase on contractual services?
So contractual services are contracts that we have with vendors. Those are related to general increases sort of across the board, across our different programs and the cost of contracts that we have. I'd have to get back to you with a specific breakdown on which funds and programs those apply to, but I can do that for you.
Okay, if you could just move the microphone just a little bit closer. There's a 343% increase in equipment replacement?
Right, the equipment replacement comes in 2 areas. One is for the MAP program. So the MAP program, which is under is a special funded program under the Telecommunications Access to Maryland program, purchases equipment that they provide to eligible participants so that they can use telephones and other communication devices in order to communicate. We also purchase equipment under our Maryland Technology Assistance Program, which is a federally funded program for demo and loan purposes, and those equipment purchases are related to that.
And then my last, let's see, 50% increase in fixed charges?
Fixed charges refers to rent, and we have a building that, well, the TAM program is moving from State Center to Charles Center in the next, probably during FY26, and the increases associated with that.
Okay, thank you. And then further down, it notes 111.7% increase in federal funding anticipated. Given the interesting weeks we have had and the intended chaos that we are experiencing, what happens if these funds just freeze without warning or evaporate altogether?
Yeah.
Well, this is uncharted territory for us.
Isn't it, though?
The 111% increase is related to the projected federal award for just 1 year next year in FY26. Doesn't incorporate the full 5 years of funding. At this point, from what we have heard, we have not received indications that the grant is going to be frozen. If it were frozen and the grant were pulled, then the work that would supposed to be performed under those two grants would cease to exist, essentially. We're hoping we don't get to that point, but these grants are specific to activities that are designed to help transition-age youth achieve better employment outcomes. And so it wouldn't necessarily change any existing funding that we had before the grants, because everything under the federal grant awards that we're anticipating would be sort of new resources, new positions, et cetera. I think that's the best summary that I can give right now, in that it's kind of a moving target, and we haven't received a definitive word that, you know, it would be taken away. Like I said, from what we know right now, it is secure.
Madam Vice Chair, I think it's important to note that these are both demonstration or pilot grants, and so it's, although we do have a program that is ongoing in terms of providing supports to Maryland's disabled community, these are two that, as important as they are also demonstration grants.
And just to follow up, as far as contingency planning, should next week bring new freezes? Are you participating in any contingency planning whatsoever?
Yeah, we are working very closely with the governor's office and the governor's team, along with all of our colleagues across the cabinet. And in fact, our deputy secretary sits on those regularly scheduled meetings to sort of plan out what if.
Right.
Thank you.
Well, thank you so much. Godspeed on that. Does anyone else have questions? I think that is all. I want to thank you so much. Thank you. Let's see, I believe we have some witnesses. Jonathan Mosen. Wonderful. Jonathan, whenever you are settled and ready, we are listening.
If my technology behaves, that will be very shortly, Madam Vice Chair.
All right, take your time, no worries.
Thank you, Madam Vice Chair and members of the committee. I'm Jonathan Mosen, and I'm Executive Director for Accessibility Excellence at the National Federation of the Blind. I'm here to support the retention of the Non-Visual Accessibility Initiative grant of $250,000 in the budget of the MDOD. This private-public partnership between MDOD and the NFB is sound public policy because it gives blind and low-vision citizens a better chance to succeed at work, at school, and in society. It's an investment in the capacity building of people with much to contribute, as long as the accessibility barriers come crashing down. The grant has specific areas of focus, and they are education, employment, training, both for blind and low-vision people, and those who may provide services to us, smart cities, and a disability inclusion fellowship program. The only certainty in technology is rapid change. Advances in AI, indoor navigation, and a range of other areas are opening up new opportunities for blind and low-vision Maryland citizens, but only if research, evaluation, and training continues. Many people across the country look with some envy at the NVAI grant and what it is delivering here in Maryland. We have exciting plans to inform and empower through this public-private partnership, and if we continue with the NVAI grant, we'll keep making a difference for blind and low-vision people and those who want to provide accessible services to us. So I thank you for your consideration.
Excellent, excellent. Thank you so much. And we do have a question. Delegate Acevedo.
Thank you, Madam Vice Chair, and thank you, sir, for being here and testifying. I had a question because you'd mentioned technology, advancing technology outside of AI. I mean, our governor earlier today during the State of the State mentioned that, you can't have economic mobility without physical mobility, to which I agree. And I'm curious as to what role the NFB is playing, whether it's advisory or otherwise, around the development of autonomous vehicles technology and what kind of an impact that would really have on the blind community here in Maryland, well, really across the country, because if we're able to develop that technology, I imagine it would be beneficial to not just folks in Maryland, but across the country. And so as you're talking about technology and AI and advancement in that, can you speak a little bit more to autonomous vehicles and what kind of impact that will have on those who are blind?
It's difficult to overstate the impact that autonomous vehicles are having on the blind community already. There are blind people in some parts of this country who are taking vehicles like Waymo, who have ensured that that technology is accessible and usable. One of the big challenges that we have at the moment is rideshare services refusing blind passengers with guide dogs, even though that's illegal. Just 2 or 3 weeks ago, my wife got a new job. We were trying to celebrate that. We just went to try to go to a restaurant like everybody else, and we were denied a rideshare ride, and it was a very unpleasant altercation simply because my wife chooses to use a guide dog as a mobility aid. With autonomous vehicles, we obviously eliminate that problem because a blind person can get into a vehicle, they can control it with an app, they don't need to deal with these sorts of issues. Just going where you want to go is something that so many people take for granted. We do have a bill that we would like to see before the legislature here that will bring autonomous vehicles to Maryland. We think that's a very important step. So I really thank you for the question. It would be a hugely impactful moment.
Thank you so much, Mr. Moser. I'm so sorry for that experience. Thank you for sharing that with us. Does anyone else have a question? Well, thank you so much for testifying, and I believe that concludes our hearing. Thank you so much.
Thank you.